So as you may know, the second half of this event each year features a special topic presentation that delves into trends and observations we've noted in previous hearings, as well as current issues impacting health insurance overall. In years past, we have subjected the leaders of our state's insurance carriers to a panel where I had the pleasure of grilling them with uncomfortable questions. It was a fun form of interrogation, at least fun for me. But this year, we are sparing them the hot seat and instead bringing in some esteemed experts and some folks from the academic world to help us focus on our selected issue. This year, we're thrilled to introduce the first Total Healthcare Expenditure model in New Hampshire. This innovative model aims to track statewide health care spending by service category and payer type, providing a unique lens of transparency into our complex healthcare delivery system, and that will be our focus this morning. Joining us to dive into that topic is Rhode Island's Health Insurance Commissioner, Cory King, and the President of Millbank Memorial Fund, Chris Koller. Both bring a wealth of knowledge and experience in developing these models at the state level, and we are immensely grateful for their willingness to share their insights with us today. But to kick off this segment, I'd like to invite our department's Director of Data Analytics, Dr. Jason Aziz, to set the stage for us. Dr. Aziz.
So, I think by now you know the context, the theme, and the title of this part of the presentation. And as the Commissioner mentioned, yes, it indeed is different than previous annual hearings. But I think you'll like it, and I think you'll find ways to integrate your interests into this important topic in our healthcare delivery system. My purpose here is not to preempt the important content that our special guest presenters are here to talk about today, rather to introduce it and ease you into the topic. I'm here to tell you about the what, the why, and the how we measure total healthcare expenditures now and moving forward in this great state of New Hampshire. So here's the what. Like, what is total healthcare expenditures and what does the model look like? It's a statewide tracking tool to help us to estimate, analyze, and report on one of the biggest expenditures in our household budget, healthcare. I'll talk more about that in a moment. We can use this as a tool to track where do we spend our money and who's spending it for us. We're remiss to think that we make these decisions on where we spend this money. It's a bigger part of a really big, yet really important system in our society. Commissioner Betancourt mentioned that we're fortunate enough to live in a part of the country for which we have access to the best healthcare in the world. Anyone who's ever gone to Longwood Medical Center may have noticed all of the hotels there. That's healthcare tourism right there. We live in New Hampshire. We see a lot of agro-tourism, but New England has a lot of healthcare tourism where people all around the world come here to reap the benefits of it. And it's important to acknowledge that part of our delivery system. It's not just about cost, but the great quality. More on that later. In the future, we hope that with improvements in precision and accuracy of this model, that we can enable the tracking of changes in that total healthcare expenditure, changes in where we spend the money based on service categories, changes on who spends the money for us, which payers are spending more or less of the money, and changes in service-specific categories throughout the whole healthcare system. That's the what. Now the why. I had the good fortune 2 weeks ago to be in the same room here learning from the UNH Institute of Health Policy and Practice and Deb Fournier, who sits right here with us right now, to tell us about this, I think, wicked problem. And I think Marissa Henn is here who defined that. And when you can make your own terms and definitions up, that's really powerful. And it takes a powerful person with a powerful message to do that. And I think she's sitting right here in this room right now. But the fact that I'm mentioning it, I think, means that it is indeed important. We have a wicked problem on our hands. And right there, this graph from Deb's presentation last week or 2 weeks ago describes this wicked problem. we do see here clearly, and we all know this based on what Jen just talked about, that total healthcare expenditures are significantly increasing. But not only that, the share of per capita expenditures are increasing at essentially an untenable rate. And so we see this, you may have seen this, I see this in other areas of my work, this and other similar graphical representations of that reality. We're spending more at the aggregate and the per capita level. What to do? This chart is highly correlated to that same construct, but just speaks at a different domain. You can see here that medical inflation, represented by the green line on top, is outpacing the inflation that we see in other expenditures that compete against healthcare expenditures at the personal level and the household level. So get used to seeing these because the problem is worsening, and people have identified that this is the economic and personal finance constraint that has us here today. Now to the why, right? So our colleague Alex Feldwebel, I think most of you know him. Like, he talks about this, and I didn't really see it in my lens, but there's a lot that I don't see. I know enough to rely on my experienced colleagues to say that healthcare is a local commodity. And until we see what's happening here at the state level, at the New Hampshire level, we don't have really a true lens on how state policy can help make things better for New Hampshire citizens. And Deb reiterated this in a different prose, but it was very useful to hear it that way, that our policymakers, our legislators here in New Hampshire need to see that this problem is indeed happening here in New Hampshire. And there's no better way for us to do that, to communicate that, than with endogenous data right here from New Hampshire health expenditures. And that's a major precipitus for the synthesis of our first total healthcare expenditure model. It's what brings me up here in front of you. So I thank both Alex and Deb for helping me to contextualize the why in this whole issue, because I have much trepidation bringing something so new, so novel, in such a great state like New Hampshire, the live free or die state. So you might already be asking this question, and this is an homage to my beautiful mother, who I talk to every day from mile high in the sky. She used to always say, Jason, you've got some nerve with everything that I did, ... but I like it. And you're probably wondering, well, you know, insurance department, they regulate insurance. What are they doing measuring total healthcare expenditures? What nerve do they have? So I thought it would be important to point out the statute that actually authorizes the commissioner to hold this public hearing to talk about healthcare premium and claims cost drivers, but also it goes on to say that the insurance commissioner shall explore and examine factors driving changes in healthcare expenditures. And that to me says we should be doing this. And here we are doing this. So that's important to me, that you understand that I'm not trying to put pressures on individual firms that serve to do their best and provide great services to New Hampshire citizens, rather to point out opportunities for which we can make this great system work better, to better serve our citizens. So I'll start. In the interest of transparency, I'm going to be transparent. Most of you who know me closely know that I am actually a nutrition scientist who became a health economist. So I'm going to share my supermarket receipt to just demonstrate what transparency can do to your health and our greater population's health. When we go supermarket shopping, I think we all do this, we all get a receipt, and we've all seen this. But notice how when we make our purchases, our expenditures, we can see where we spent our money. And let's all agree that, you know, diet and nutrition really directly affects our health. I can look at where my nutrition and health expenditures with regards to nutrition are allocated to different domains in the supermarket, like grocery, produce, wine, at least like yogurt, which I think everybody should eat. But say I went to the doctor and I got diagnosed with some chronic illness. I can look back at my supermarket receipt and say, hey, you know, I spent a lot on snack foods, and I think I can reallocate some of my investments towards produce, thereby having a direct impact on my health. Do you see how at the micro level, transparency can directly affect the outcome? In this case, our health. That's no different than at the macro level. Let me step back to the micro level. Well, this cash back, I have to talk to my colleague's daughter about that, but that's another type of social transparency effect. More on that later or when I get home. But I just wanted to point out that New Hampshire has a pretty impressive, one which I'm proud of, history of price transparency in healthcare. You may know it as New Hampshire Health Cost. If you don't know it, then I hope you'll go and explore our website now to find out how our citizens and also providers and even payers of purchases of health insurance can go and look at what we pay for healthcare. It's egregious to think that we have no idea what we pay for healthcare, given that we pay so much for it. 18% of every dollar goes to healthcare in the U.S. That's a lot. We also have more intermediate level transparency endeavors like cost and utilization for prescription drugs, where if you were paying attention to Jen's presentation, you can see that there's a non-trivial expenditure share for prescription drugs on our healthcare system and on our household budgets. Caveat emptor, that doesn't make us worse off. Prescription drugs are changing clinical care delivery, oftentimes for the better. So you can visit our website there, and that link is embedded in this file, which will be shared on our website. So why now in New Hampshire? I just told you about our microeconomic level investments. This total healthcare expenditure model is really a macro level investment in knowledge and information. The New Hampshire Insurance Department, in our healthcare data analytics unit, we have a plethora of healthcare data information, only of which a fraction we use, and we want to change that. We have colleagues here from Health and Human Services, Mary Fields, from UNH, that do a lot with healthcare data. We don't own that data. This concept of data ownership, I want it to change. We call it data stewardship. We at the Insurance Department or elsewhere at any state agency, we're not owners of data. The citizens of New Hampshire and the United States own this data. We're compelled to collect, protect, assimilate, analyze, and report responsibly on these data. This is a public good. And as such, we're compelled to do this for the greater public. It's a public good. So here's the methodology. I'll go quick, and I'll let our great speaker, Cory King, follow up on that, because we've standardized and mimicked their methodology, and it's the standard approach to measuring this domain, and 7 or 8 other states already doing this. Okay, so first we measure total medical expenditure by market type or payer type. It looks like this. And I do need myself a good equation, so this is not algebra, it's just basic arithmetic. The algebra comes later. So you can see the different payer types for which we aggregate data in the total medical expenditures domains, and you've got that. We put that all together, and it's a really big number. You'll see it in a minute. Then we measure essentially what we call net cost of private health insurance, which is really a direct or surrogate measure of the administrative cost of healthcare delivery in our system. Let's face it, one of Jen's early slides showed that I think 4.7% of the state of New Hampshire, residents, are uninsured. That means almost everybody's insured. And what that means is that almost everybody uses insurance to administer in or finance, pay for their health care. So that's a pretty holistic measure taken in that context. The net cost of private health insurance. It looks like this. For each payer type or market type, I toggle back and forth. For the purposes of this model, they're analogous. Then we put it all together and have a holistic view of what we're spending our money on healthcare in New Hampshire. And it looks like that. And I always need an equation, an equal sign in there, so things add up. We want them to add up, right? And they do indeed add up nicely. So enough on that. Quickly, I'll demonstrate some preliminary results. You can find these results in a report that will probably be publishing in mid-January once we synthesize everything and confer with a lot of our colleagues sitting in this room on the best, most responsible, and contextually relevant way to express them in all these different permutations of these data expressions. So you can see the top table. I wanted to show you this. This is like that number. Drum roll, please. What's the number? It's over $13 billion in 2022 in the state of New Hampshire we spent on healthcare. That's astonishing to me, but interestingly, not that surprising to my very well tenured and experienced healthcare colleagues. Oh, that's what I expected to see. I didn't expect to see that next year. I won't be so surprised. From a per capita standpoint, it's like $9,300 a year, which is on par with a lot of other states close by. That pleases me because I've worried for 6 months about this discussion right here, right now, that, we weren't going to get precise and accurate point estimates to share with our great public. I don't have that worry anymore. We did a good job. Our colleagues at Oliver Wyman, Jen and her team, did a fantastic job, and so did industry, supporting us, providing us the data to help inform our public on this important metric. So the fact that we came really close to what we would expect, so the observed versus the expected value is close, and that it matches up with what our neighbors communicate as their per capita cost, it makes me feel really good standing here in front of you today. This chart right here, we produced, it's Cory, you might see that and say, that looks familiar. We're impressed by our neighbors and how they've taken these data and communicated to the various entities that they work with. This is another permutation that you'll see in our 2025 report. This is the graphic that I'm actually, surprisingly, maybe counterintuitively, most proud of. Is the first New Hampshire healthcare dollar. Now, I know many of you have seen the healthcare dollar from various publications. I'm most used to the USDA food dollar, and I think it's really cool and it's really insightful. Despite its inherent simplicity, our legislature asked for simple, interpretable data instruments that can inform their legislative endeavors, their policy initiatives. I see the New Hampshire healthcare dollar as being one of those tools, or at least, if nothing at all, an example of that tool. It's a crude partitioning of all of the different things that we spend our healthcare dollar on. You can expect to see this in our 2025 report. Important, I always like metadata, and I really, as part of a transparency effort, you need to have transparency embedded into that with regards to the source of the data, what's in, what's out, who it's representative of. And I indeed do that. I'll go through this quickly and not take time, but you can see it right there. I'll toggle to the next year, 2022, the healthcare dollar. It looks similar, subtle differences. But these are great permutations of that holistic aggregate data that can help advance policy that's informed with sound data reporting. And that's important to us at the Insurance Department, and I know my other colleagues sitting in this room, it's important to them too. So I'll summarize and get on to the real brains of this part of the presentation. These are some key features. The purpose of this instrument is not for the Insurance Department to play a role in policy. We're not a policy agency. We're an information agency. We provide information for the policymakers to make key decisions, and we take that responsibility seriously. It's key that we point that out. I'd like to have everyone in this room consider what their role might be in informing future permutations of this model. Providing data, suggesting different types of data analyses and reports using this, and target audiences and maybe target legislators that might be able to identify new legislation that can make our healthcare system work better and serve our citizens of the great state. Okay? So thank you for the privilege to talk to you about this, being open, not asking, what gives you the nerve, right? Because now you have that answer. And we'll take questions about all this after our guest presenters speak. But for now, I'd like to introduce Commissioner Cory King. He's the Health Insurance Commissioner from Rhode Island. They've done this project. He's helped inform the New Hampshire Insurance Department iteratively on how to not just do this, but do a really good job at this. Now, I think he's going to talk to you about what we can all do with this important metric. Commissioner King.
Good morning, everyone. Thank you for the introduction. And Commissioner Betancourt, thank you for the ability to come and speak to this audience today. I was really impressed by your annual report. We work with Oliver Wyman, specifically Jen, to do an annual report for Rhode Island. Yours is actually a lot deeper than ours. So not this year, but next year. We should talk about that and learn a lot from what you're doing here. So Jason did an excellent job articulating why you should measure total healthcare expenditures in your state. And I hope that the message of my presentation is that you can do it. You can do it in a way that informs legislators, consumers, employers, and others in state government who may have a stake in this. But first, I am compelled to give you a little bit of background on the Office of the Health Insurance Commissioner. In Rhode Island, our institutional structure is a bit unique. 20 years ago, the legislature chose to carve all of the health insurance laws out of the Department of Business Regulation and place them under a government-appointed insurance commissioner, a health insurance commissioner. Imagine the totality of insurance laws. You just cut out all the health insurance and you put it under someone else. So we have another commissioner who oversees all the other types of insurance in the state. When the legislature created the Office of the Health Insurance Commissioner, which I will refer to as OHIC going forward, we were given a very clear mandate and a broad mandate. So we characterize ourselves as Rhode Island's commercial health insurance and policy reform and regulatory enforcement agency, and consumer protection is at the core of what we do. But we also are required to ensure the fair treatment of providers, to guard the solvency of insurers, which is a traditional function of any insurance regulator, and to improve the healthcare system as a whole with an emphasis on access, quality, and affordability. So what are some of our powers? Solvency. We protect the solvency of our domestic health insurers. Prior approval rate review. We review rates in the individual, small group, and large group market. And the criterion, the standards which the health insurance must meet for us to approve their rates is that they're consistent with the proper conduct of their business and with the interest of the public. And it's my position, and has been the position of every health insurance commissioner, that the public has an interest in affordable health insurance. We also perform form reviews. So we review the coverage contracts that are in place between the insurance companies and their members. We do that in great detail, looking at changes from year to year in red lines to ensure that the benefits are not discriminatory, that all state and federal mandated benefits are included. We also perform periodic market conduct examinations. We have an ongoing examination into behavioral health parity. And we have a host of other powers, certifying utilization and review agents. A more recent power that we have been granted is to review and make recommendations for provider reimbursement rates in the Medicaid space around behavioral health, home and community-based services, early intervention, and a few other social and human services. That is not a traditional function of an insurance department, but it's really intellectually engaging, and we're proud of it. So I want to give you my favorite part of our statute. So we have a host of powers and duties which look a lot like Commissioner Betancourt's powers and duties, but the General Assembly specifically enumerates some purposes of the office. And of course, statutorily, reviewing solvency, ensuring fair treatment of providers, and protecting the interests of consumers are on that list. But this is one that you may not find in any other insurance regulator's statute. And that is, with respect to health insurance defined under Rhode Island law, the Health Insurance Commissioner shall discharge the powers and duties of office to view the healthcare system as a comprehensive entity and encourage and direct insurers towards policies that advance the welfare of the public through overall efficiency, improved healthcare quality, and appropriate access. So when we perform rate reviews, form reviews, any regulatory decision we make should be made toward advancing that end. That is our mission. So why do we measure total healthcare expenditures in the state? Well, we want to compare them to a predetermined benchmark, what we call our cost growth target. So the measurement of expenditures is foundational to that, but we want to impose a performance metric on the healthcare system to keep care affordable for working Rhode Islanders, employers, and taxpayers. So I'm going to give you some background on this work. In 2018, our governor wanted the office to convene a Rhode Island Cost Trends Steering Committee and to work with this committee to restrain healthcare spending growth and improve affordability in the state by establishing a cost growth target. The committee established a statewide per-person annual cost growth target of 3.2% that was initially in place for a 4-year period from 2019 through 2022. The 3.2% is based on a calculation of future expected economic growth in the state. And to be totally transparent on much of this work, whether it be the total healthcare expenditure measurement or the development of the cost growth target, we borrowed from Massachusetts. Massachusetts was out front on this, and we cribbed from them heavily. So that's a message to New Hampshire. Don't reinvent the wheel, right? In 2023, we had to renegotiate the targets because we actually don't have a statute that sets a cost growth target. We have the voluntary action and commitment of the health insurers, the providers, and other interested parties that we have convened who have agreed to this target and have agreed to take actions to try to meet it. We established new targets for 2023 through 2027, which methodologically are a little bit different in that we include, most of it is projected state economic growth, but we blend that with projected median household income to import more of a consumer or household focused element. So I'm going to get into some of the nitty-gritty of how we measure healthcare spending. The first piece is to look at total medical expenditures. And I should take a step back and just say that we collect this data directly from the insurers in the state. They report for their commercial business, inclusive of their self-insured business. They report for Medicare Advantage and for Medicaid managed care. We have over 90% of our Medicaid enrollees in Rhode Island enrolled in managed care. We also collect data from relevant state agencies and CMS to bring in the rest. But our total medical expense measurement is all incurred expenses or allowed claims for Rhode Island residents for all healthcare services, regardless of where the care was delivered, and regardless of the situs of the member's plan. So you'll notice in Jen's presentation, her focus was on New Hampshire situs business. And in our presentation and our rate reviews that we conduct, it's all situs-based. But for this work, we look at a slightly different population. We want to understand healthcare spending from a resident perspective. And we have insurance companies that can report expenditures for Rhode Island residents who may be covered under a Massachusetts or a Connecticut employer. The next piece, and should look pretty familiar to you, the net costs of private health insurance. So these are the costs associated with having private health insurance in the state, largely administrative costs. And together, those quantities sum up to be total healthcare expenditures. Once we collect the reports from the carriers in October, we begin to validate the data. We hold data validation calls with them. This is not work that you can simply take a report and publish it. You have to dig into the data, ask questions. So there are resources that are required toward that end. But once we're confident that what is reported to us is accurate, we proceed to perform measurement at a number of levels using slightly different metrics. So at the highest level, we want to know what is per capita spending for the state. And that's where we look at total healthcare expenditures, which is total medical expenditures plus the net cost of private health insurance. But since we have a cost growth target, which again is a performance metric that we want to compare the market to, we begin to look at spending within each of the markets and compare that to the target. So we look at total medical expense in the commercial market, inclusive of the self-insured, and we look at it for Medicare and for Medicaid. We do not include the net cost of private health insurance at the market level. We go deeper and we look at the payer level. So we look at the payer's year-over-year performance by line of business and measure per capita spending changes. And then we go to the provider level. And I can talk to some of the nuances of how we either measure or adjust the data the lower we go. But our unit of accountability at the provider level is the accountable care organization or accountable entity, which is what our Medicaid program calls accountable care organizations. I wish we could have just aligned the terms and used one. But you can see the specific providers whose performance is measured. We do impose a minimum attributed lives threshold. So reporting for a particular line of business may be suppressed. Some of these providers are community health centers that may not have a sufficient volume of commercial business to be included for public reporting, but they certainly have enough Medicaid. And when we go from the market to the payer and provider level, we begin to make some adjustments. All of these methodological decisions were reviewed, discussed, and ultimately agreed to by our cost trend steering committee. We're not promulgating regulations here. We're working in collaboration with industry to meet this objective, which is to improve transparency and measure 20% of our economy. At the payer and the provider level, we truncate claims at $100,000. We're actually now in the process of revisiting those truncation points because inflation. We also age, sex, risk adjust. We don't perform clinical risk adjustment, but we measure spending by age, sex bands, and then we begin to adjust over time. And when we present public performance at the payer and the provider level, since we're working with PMPMs that are an average, you can calculate a standard deviation around that, and we publish confidence intervals too. So I'm going to share some of our data with you. Again, you can do this. And I was actually, when Jason was showing us the per capita spending in New Hampshire, I made sure to look at ours, and it's very close. And this is 2022 data, I should add. We are currently validating 2023 data, and we'll publish it next spring. But this shows you that in Rhode Island in 2022, our per capita total healthcare expenditures, inclusive of the net cost of private health insurance, was $9,313. And you can see each year the year-over-year change in per capita spending. The baseline performance year 2019, we were above our cost growth target. In 2020, we met the cost growth target because of pandemic suppressed utilization. There was at the state level a rebound in expenditures, but it was most acute in the commercial market, less so in Medicaid and Medicare. So we actually met our cost growth target at a state level in 2021. We met it again at 2022. And when you dig into our public reporting, you can identify which payer category is actually driving this result. In 2022, it was actually low per capita Medicare spending growth that brought down the state average. But over time, we've kept the overall per capita spending in control. I should also point out that the data that I'm showing you here is net of pharmacy rebates. So we strip out all of those pricing distortions. Anyway, so Jason showed you the chart that they copied from us. So this is our version of it. Spending in Rhode Island within our data collection was roughly $9 billion in 2022. And you can see how it's distributed across the various types of insurance. There are some payers that we don't have in our data set. For instance, Aetna, Cigna have a small number of self-insured and even a smaller number of fully insured covered lives in the market. They're not in here. So don't let the perfect be the enemy of the good on this. What happened in 2022 for spending growth per capita in each of the markets? So I look at the commercial market because that is where I discharge my powers and duties. Rhode Island spent $2.34 billion in the commercial market, and this is total medical spending, for a per capita value of $6,378. You can see that our 2022 growth from 2021 in commercial was 3.3%, which was just above our cost growth target. Medicaid came in a tenth of a point lower, and Medicare really brought down the overall state growth rate. This digs into the net cost of private health insurance, which is kind of a messy measure. Intuitively, you can think of it as the difference between earned premium and, payments for patient-related care, so admin profit. You try to capture the self-insured service fees under their ACO contracts as well. That's where it gets a little more challenging. And these measures can be very volatile from year to year. So when you dig into the specific lines of business, you can see significant swings either in the negative or positive direction. And that can be driven by whether an insurer was profitable one year and unprofitable the next. So changes in underwriting performance can swing these numbers quite a bit. All right, so we dig into service categories because we want to understand what's driving per capita spending. All right, so let me reorient you to this chart. So this looks at statewide spending. On the y-axis, we have the year-over-year change in spending per capita, and on the x-axis, per capita spending. Within the coordinate plane, the center of the bubble is that point, the combination of year-over-year change and per capita spending, and then the width of the bubble is the contribution to trend. So this is a different version of Jen's slide that was in bar format. And if you want to know how to calculate the contribution to trend, ask Jen. Or ask Bella. At the state level, we identified the key driver of per capita spending to be a reduction in per capita hospital inpatient, or I should say inpatient facility, just to be more clear. The positive factors, though, were growth in hospital outpatient or outpatient facility and long-term care. In the commercial market, the story is a little bit different. As you can see, let me go back one slide. The most significant driver was outpatient facility with a 4.8% year-over-year growth rate. There was a significant growth in non-claims that can be driven by shifts in shared savings that are earned by accountable care organizations year over year. So you don't earn savings, or maybe you incur a loss one year, but you earn savings the next. That can lead to a lot of volatility. So that's good and everything. We're measuring total healthcare spending, and we're able to decompose it into some of the major intuitive service categories and understand what are the drivers of year-over-year increases. But what it doesn't tell us is underneath the hood, is it utilization? Is it unit cost? Is it some other factor that's leading to these service category changes that roll up to the total? And that's where I was impressed by some of your report for the New Hampshire insurance market is you asked for data from the carriers to publicize that, and that's where we're going to have a chat about next year's report, because I'd love to see that for our market too. Again, thank you for the inspiration. But for our work, we want to understand, again, what are those specific service drivers? So I'm going to take you to a totally different database now. We have an all-payer claims database in Rhode Island, and I believe you have an all-payer claims database too. Our steering committee was insistent that if you're going to set a cost growth target and expect that we meet it, and also publicize our performance and potentially publicly shame us using the Massachusetts model, you have to also execute on a data use strategy where we can identify areas of opportunity. So this may be kind of small for you to see, but we've taken the Rhode Island all-payer claims database, which is payments for Rhode Island residents. Some of the self-insured are not in there. We have a lot of self-insured in our database, fortunately. But we publish this data on the OHIC Data Hub, and we utilize it to really dig into these service category contributors. In 2022, we found that the hospital outpatient PMPM increases were largely driven by what we call payment per unit or average payment, not by utilization. In fact, we found that payment per unit increased 8% and utilization decreased 2%. In the retail pharmacy world, payment per unit increased over 12% while utilization increased just under 1%. In our APCD, we are unable to net out pharmacy rebates, so just please be aware of that. But this gives us a deeper dive into what the specific drivers are. In the retail pharmacy space, again, this is a chart that I think is really informative for us because, again, states don't have good solutions for addressing drug spending, drug prices systematically. Whatever you do will likely draw litigation. You should still do it and fight that battle. But we can't achieve affordable health insurance unless we tackle this issue. And it's also taking resources away from investments in our healthcare workforce. But you can see over time, the key driver of overall per member per month spending changes for retail pharmacy has been payment per unit. Okay, so just a few key takeaways. Again, you can do this. You've got the data, you've got the resources. You also can't improve what you can't measure. So the transparency that Jason spoke to is critically important. Transparency lays the groundwork for action. Never dismiss a potential policy as unfeasible, because once you lay the groundwork for it and you say, the reason we have to control healthcare spending growth is because it increases people's premiums. And when people's premiums increases, money is taken out of their paycheck or their wages are attenuated. So that is the real impact. I think that pairing measurement with a cost growth target is a natural next step. And that's what we've done in Rhode Island. The cost growth target also acts as a unifying logic for many of our initiatives. We have other affordability initiatives in the state in addition to the primary care expenditure requirement. Through regulation, we cap hospital facility price growth. So the cost growth target helps bring all of that together. It helps bring together the focus on payment reform, price control, primary care investment. And finally, since we don't have statute, we had to work together. And I found that this work requires a lot of collaboration and good faith on all sides. I chair our cost trend steering committee with our largest payer and a representative of a primary care group that is owned by our largest provider organization. And as we've done this, it's required a lot of time commitment on each side. So the payers and the providers have to commit their time to reviewing the data and advising us on potential changes. So it requires a lot of collaboration. And that is an overview of our work. So happy to answer questions. And you want to come up and introduce Chris after, or now? Yeah.
No, we get a question with that.
Yep.
So, thank you so much.
So let's thank Commissioner King for that talk. And it's refreshing to hear that, we've followed suit with that work and that we're right on target, doing good work. It's important to us. Okay, so next we're going to introduce Christopher Koller from the Millbank Memorial Fund. He's the former Rhode Island Health Insurance Commissioner, and he's going to talk about what states have done. They do a lot of work informing states on this exact endeavor, what states have done and what states can do to potentiate the social and public and economic impact of measuring total healthcare expenditures. Christopher Koller.
So thanks very much. You heard what we've got for evidence-based, a database in New Hampshire. You've got a sense from Rhode Island as to where they're going with it, what they do with it. And my job is to sort of describe what other states in the country are doing with the same sort of information, the same cost growth targets program, as you guys make your decision. Okay, as we gather this data, as we get this information, this analysis, what do we want to do with it? What's the solution that makes sense for New Hampshire? I do want to note, I was the first health insurance commissioner in Rhode Island. However, a qualification to be health insurance commissioner in Rhode Island is not that your initials are CK. I just realized that, Cory. So this is what the Millbank Memorial Fund does. My comms director always says, you got to put this up here, so now you can tell her that I've done that. I do want to, before I go on, we work with different states. It's really a privilege, actually, to come in and get the feel for different states and what's going on. New Hampshire is not like Vermont, not like Massachusetts, and it's just more than fun, it's a privilege to understand. This is federalism in action. This is sort of states trying to figure out what's going on with it. The other thing I want to do is thank Commissioner Betancourt for this work and encourage support for the insurance department as they do this. It's a really important role. It's a gathering of the information. And so kudos to the folks in New Hampshire and that insurance department for doing this. You always start in policy by defining the problem. What is the problem that we're trying to solve? Is it that, and it can differ. This is one statement of the problem, that so long as workers' earnings are increasing at that black line, I thought, Jason, I could read back there, but my eyes are getting bad, so I'm going to do it here and turn around a little bit. As long as workers' earnings are increasing, actually at the blue line, the black line, inflation, the blue, and healthcare is going up this way, we've got a problem. So we got a problem from an affordability standpoint. The other way to think about this is that so long as healthcare is going up at this, remember those of us who are dinosaurs said healthcare is 9% of the GDP. It cannot go on like this. Well, now it's at 18, 19, 20%. And dollars that are spent in healthcare might be more effectively for life, liberty, and the pursuit of happiness might be more effectively spent someplace else, in people's back pocket, in social services. But right now, more and more of it's being spent in healthcare. So whether you define the problem as this gap between workers' earnings and what they have to pay in healthcare, or the larger issue of what it means for healthcare to consume a bigger and bigger part of our economy, you want to define the problem going forward. And both of those are very tangible. They're why actually the fund does this work. We exist to help states improve population health and health equity. Evidence is pretty clear that if you want to do that, there are better places to spend the dollar than in our healthcare system. You can define the problem in terms of, this is more detail on the affordability issue from an employee perspective. I'm not going to go into that. I do want to know from an organizing standpoint, if you think about how to talk about affordability, where it hits home even more than people's cost sharing is the portion of people with medical debt. And so we're seeing a lot of activity on this. This is shaded based on the severity of it. Darker is worse. It's kind of interesting that Vermont and New Hampshire, this data from 2021, even though Vermont Medicaid have both expanded Medicaid, they're a little bit darker. So you've got a medical debt issue. And frankly, as you think about organizing and developing policy responses, focusing on these particular set of people as sort of the tip of the spear of the problem might not be a bad place to focus efforts. And by the way, just raising money to pay off medical debt, it solves that particular problem for that individual. It doesn't get at the underlying systemic issue. These people in medical debt is driven by rising healthcare costs. It has effects, affordability has effects on the rest of the system. We were talking about primary care spend. This is something that the fund works hard on. We've got a dashboard. I would encourage you, it gets at some of this apples to apples comparison of how does New Hampshire's primary care spend compared to compared to other states. The bigger picture, though, is that as a country, our primary care delivery system is getting weaker and weaker. And that's a problem across the country. There are things that the states can do about it. We were talking about with primary care spend. It's also a federal issue. It is a casualty of affordability. We are misallocating the money. All that money within healthcare is going to the wrong places to improve population health and health equity. And this just sort of describes how affordability, you're going to take on affordability. I think I'll do my systemic approach here. One way to address affordability, and it's one that we do very well, is to get someone else to pay for it. It's like a game of hot potato. So we will shift costs from the feds to the states. We'll shift costs from employers to employees. We will shift costs to providers in terms of bad debt. And we have to get at a more systemic solution than just shifting costs back and forth. We're going to fight that again next year, regardless of who's in Congress, with the question of continuing the subsidies that have allowed exchange enrollments to continue. We have to get at the underlying cost drivers. So you heard Cory talk about the healthcare cost growth targets. What the message here is that, Massachusetts came up with the first idea. It was contagious. It traveled down to Rhode Island. We have the privilege of working with the Peterson Center on Healthcare to fund a collaborative states that are learning to do this work. There are 5 states, I think I've got them on the next page, that get technical support through the collaborative, and then we have a number of friends and neighbors that participate in it. New Hampshire is a participant, Connecticut's in it, Oregon, New Jersey, and Washington. We're really privileged to have the support of the Peterson Center as we do this work, not just for the funds for the technical assistance, but for learning what different states do. And I've got a slide with that later on. These are the elements, though, of any cost growth target model. You see what Cory talked about here, and the path that Massachusetts and Rhode Island followed. These are pretty consistent. Where it starts to vary by state is that last bullet. The discussion is going to be different because New Hampshire is different from Vermont, is different from Oregon or Washington. And so the policy responses that you're going to come up with are unique to your particular delivery system, payer environment, culture, things like that. But these steps are pretty much, they don't vary so much. And I should note, by the way, just say, this is a very kind of realistic response to where we are as a country. We got multiple payers. Some of this private sector, there's public sector, we got state and federal, and we're not wishing our way to single payer or to vouchers for all. We're dealing with the reality of what we have, which is a whole bunch of different payers, different data sources. We got to bring them together to get a full picture. But, and I did not even know Jason. I don't see Jason. Oh, there you are. This is my punchline. I didn't even know about your nutritionist background, but the fundamental principle is you cannot lose weight without a scale, which is a fancier way to say we improve what we measure. Total healthcare expenditures is the scale. Cost growth targets is the setting the desire for what your target weight to be. The policies are like how you're going to get there. I never thought about it all that way. But that's this is what you're talking about today is your scale and the process for figuring out what is it that we want to be going forward. And then the cost growth targets is the process by which you do the work. These are some of the benefits. What and Cory talked about them, it is remarkable how consistent this is. It is not so much that people land on a a single solution, but you're creating a conversation with folks, and you're really working hard, Cory understates it, that to get different voices at the table, not just the 20%. It's really important to get more than the payers and the providers at the table. You've got to get the people who are paying the rates and the consumers to create a discussion around, one, create a common fact base, and then create a discussion about what we're going to do with it. This is a Peterson Millbank program. I already went through that. We've got, if you're interested in learning about other states, we've got a whole section on our website where Rhode Island publications and the other states are all there, and then we can lead you to the states' websites as well. And I would, again, a lot of this is learning from Massachusetts. Cory's absolutely right. In the same way that we're learning about the Affordable Care Act. Now, you guys are adjacent to Mass, just like we are. You know, we don't like those carpetbaggers who come down to us, and you probably don't either. But we have to acknowledge that every once in a while, the smarty pants people in Massachusetts come up with a good idea that we can then copy for ourselves. So, 5 lessons. It's a little bit hard to read, but I want to go through them, and then we can have a conversation. The first is exactly what Cory said. You can do this. It's hard to read. These are the 5 states with most recent performance that was published in Health Affairs. The blue is the target that they set, and the orange is their performance, I think, for 2022. You can see Rhode Island off to the right. Interesting discussion then maybe to learn about Rhode Island's policy responses. But we're getting some comparability. Why is it that some states are doing better? Again, this is across all payers. This is commercial Medicare and Medicaid, which is sort of the next frontier for your total healthcare expenditure work, is to look across all payers. The second, again, this is consistent. It's what you saw documented in your New Hampshire data. Cory's got as well. All the growth of this in commercial. Medicare and Medicaid are relatively flat. There is a story that's going on here, something about the way the commercial market functions relative to Medicare and Medicaid. That's good, but that starts to be a conversation about what the policy responses are. This is Cory's bubbles again. Same lesson that you guys got and that we heard this morning in the first report. The expenditure growth is in outpatient hospital and pharmacy, and it is price, not utilization. So remarkably consistent across the different states as we get more comparability here. Fourth lesson is when you present this information, the providers don't say, "Thank you very much. We're so glad you did this. Thank you for sharing this. You're absolutely right." No, they have concerns. They contest the data. Was it accurate? They cite alleged and alleged is important because then we have a conversation about what are appropriate costs. There are important labor cost issues. These conversations never happen, or if they do, it is a narrative that is often controlled by who is speaking. And so when you have data that's out there that's coming, frankly, from a commission, from an independent source, we can then have a conversation about what to do with it. But one, to agree on the facts, and then have a conversation about what to do with it. And the fifth lesson, and this is really important, is what have the states done with it? This is a busy slide, but I would pay attention to the 5 columns, and then we cite specific states. You can have responses about increased oversight and transparency. You can promote increased value-based care transition. You can go after the price piece directly, take the bull by the horns. Rhode Island's done this. Oregon is doing it. You can talk about insurance rate review and antitrust regulation. And then you can talk about what's the particular role of government-funded health plans. This is where the state-specific conversation happens. This is where conversations like you have right now, very live for you, discussions about hospital consolidation. Remember the play that we documented. Systems get bigger. They use their market power to negotiate larger commercial prices to make up for supposed public payer shortfalls. Let's have a conversation about what is appropriate system size, what's our attitude around what do we want them to compete on, how do we oversee the commercial market, has the horse left the barn in some places? That could be the case in some monopolistic markets, and then economists are right. How do we respond to that? But this is the local conversation, and I will say, my last editorial piece, this is the secret sauce that places like New Hampshire have. You can get people in a room and have the discussion. You can't do that in Massachusetts. You certainly can't do that in California. But you guys can develop the trusting relationships to say, okay, how do we acknowledge that healthcare is a big employer, but we can't go on like this forever. And those are really hard conversations. Cory is understating the amount of work that's done to build trust around the information, but it's really important. And I would just encourage you to do it in Rhode Island, in New Hampshire, based on a fact base. Too much here. I just put this up because this actually came from that institute that's got green in it, that's up I-87 in the Upper Valley. A paper that came out with Elliot Fisher, Cory Koller, myself, and Elena Barundi, talking about here, fundamentally, in a market where competition, if you're in a market that's been consolidated, where frankly provider competition doesn't work anymore, these are some of the elements you have to think about. You got to think about comprehensive oversight and spending growth targets. That's what you guys are doing here. Discuss hospital global budgets. Do we start to think about hospitals like we do educational institutions? All payer accountable care organizations. Cory talked about the penetration of those in Rhode Island. We expand those. And then thinking about how do we deal with providers with monopoly pricing power, must-have providers who have to be in the network. Again, the solution in New Hampshire is going to be different from other places, but in markets where the horse has left the barn, these are the things that we think you have to start thinking about. So in summary, this is the Oracle of Omaha, talks about healthcare as the tapeworm of the economy. I think that's a fundamental way of stating the affordability issue. Providers behave to preserve their interests, which we have to expect them to do. They have to stay in business. They have to pay their employees, and we are finding our experience that shows us how they consolidate to gain power so they can achieve their institutional purposes. Affordability is going to get worse. We're not going to innovate our way out of the problem. We're not going to have a competitive market. We cannot subsidize our way out of the problem. So I think we have to pay attention to these issues. The market's not going to fix ourselves, particularly in consolidated places. And as hopefully Cory's demonstrated, as we're seeing in other states, cost growth targets provide a base, an information base, a transparency, a structure, and a process to monitor performance and design, and then to come up with a policy agenda that makes sense for the particular state in light of what it is that makes New Hampshire so beautiful and interesting. So congratulations on this work. And I think, Jason, we got the discussion right now, right? Okay, thank you.
So thank you so much. That was so informative, and another affirmation that we're doing the right job and we're on the right track. So we're going to sit down here. If there's any questions, both here in the auditorium and with our online viewers, we're very numerous. Let's hear them.
Edward, your knowledge, there's any question there?
All right, questions. And as you're thinking about the question you have, I just want to be very clear with Chris. We are always happy to take Massachusetts' money when they want to come up here, shop, or whatever. They're always welcome. Leave their dollars right here. We'll take care of it. Yes, Commissioner.
Thank you so much for having gathered this fall. Thanks to Rector and perhaps Steve and Gus to say how much they were gathering. Have the shelf that health equity as comment efforts that obviously the results. Question I have is, about a week ago, many of us were here, and Deb put up a slide of sort of a menu of things that we could do if we were to this.
So it was, as was said, it was a really inspiring day, similar to this, in terms of motivating us toward action. And so Deb had a slide that I believe was informed by lots of different stakeholders about what are the things New Hampshire could take on. And there were a number that were highlighted in green, and one of them was the growth benchmarking that we just heard about. But I guess the question I have is, it was in the column, as I recall, around accountability and transparency on Deb's chart. But what I'm seeing in Chris's slides is that it could really motivate change in more of a value-based direction in terms of kind of actionable outcomes. So I wonder if we're sort of underselling ourselves, not to be critical of where Deb's put it, but instead to say, to like elevate it, that taking that type of work on would not only inform the transparency and the regulatory piece, but actually potentially move us much further. So just wondering if you could sort of speak to the impact of that one menu item as we prioritize in New Hampshire.
So I think this is a question for Cory. I want to make sure when you say take on that work, do you mean the work of advancing value-based care and accountability?
I think kind of prioritizing just the impact of if we were to have a benchmark in New Hampshire, similar to what Rhode Island and Massachusetts would do. I think the framing I've heard to date has more been around increased transparency and greater oversight. But what does it take to, is there potential that's far greater to advance cost savings, affordability through the benchmarking approach?
Yeah, we've been living with it. So.
Yeah.
How's it triggered the conversation in Rhode Island?
So Rhode Island had established a baseline in value-based payment prior to the development of a cost growth target. We were pretty advanced in the accountable care movement. But when I look at my kind of model of the healthcare system is the major players are the insurance companies, who are the payers that represent the employers and any individuals who purchase their own insurance, and the providers. And so much of the outcomes that we observe in the claims experience that the New Hampshire department deals with in the annual rate filings is a product of what happens at the negotiating table between the provider and the payer. So the incentive structures, the fee schedules, the way that insurance companies allocate the scarce premium dollar to support things like care management at the provider level all really matter. So I view value-based payment as the mechanism for the delivery system to achieve these benchmarks. It's probably not sufficient to just say, don't grow faster than the economy and then not change anything. What they have to do is take the totality of medical expense and put some guardrails and expectations around that. So the ACOs, I think, are a microcosm of what we're doing at the macro level with state cost growth targets and total healthcare expenditure measurement. But do you have any thoughts?
Yeah, the piece I would add is something that's marked Rhode Island particularly, but also some of these other states, is a recognition that our delivery system is fundamentally out of balance. That to get to shared goals of improved health equity, livable trends, our delivery system, we spend way too much on specialty care and not enough on primary care. And so a different question for every state is how do we promote that rebalancing? Is it enough to do a cost growth target? Is it enough to say, ACOs are great, we hope you guys do it? Do you have to push ACOs harder to get that sort of delivery system realignment? Or do you have to put a thumb on the scale of primary care and just have this kind of say, lead to say we're out of balance and our goal here is to put more money into primary care. That's why we hit on this primary care spend measure, is to say, there are different ways to get there, but until you have a more primary care oriented delivery system, we're not gonna get there. So I think, Marissa, what I would add to what Cory would say is not being afraid to, in response to the evidence, to emphasize some of the findings of the evidence, and particularly around the lack of balance in the delivery system and the importance of primary care. Even if we have food fights about how to get there, we can at least agree that it's not only life, liberty, and the pursuit of happiness, but it's a more balanced delivery system. And a more balanced delivery system means we spend more on primary care.
The questions. Yep, right here in the front.
Thank you. As one of the in-house family doctors, thank you for highlighting primary care.
Thank you for your work.
Thank you. So I'm curious to hear a little bit more in Rhode Island how the accountable care organizations work, because we know that evidence demonstrates there's cost savings when we have physician-led accountable care organizations as opposed to hospital-led accountable care organizations. And so I'd love for you to speak a little bit more on how are you holding accountable those larger health systems from a cost standpoint. And secondarily, from a provider level perspective, what is Rhode Island thinking about as far as making sure that those increased primary care dollars are actually going to the providers that are providing the care and incentivizing that work?
You have asked so many timely and pertinent questions.
Better watch out. He's going to come hire you to work in Rhode Island.
No, that time.
Okay. Go ahead.
So on the topic of accountable care, your summary of the literature is accurate in that physician-led ACOs have tended to be more effective than hospital-led ACOs, and maybe we all know why that probably is. There has been a significant change in the Rhode Island market where for years we had a higher performing physician-led ACO that was then subsequently purchased by a hospital-based system. I don't know whether that has had any impact on that accountable care organization's performance, but today we don't have any independent primary care-led ACOs in the market. So that would be something interesting to watch. We have other mechanisms besides total cost of care contracts that are based on attributed populations. We have regulations through OHIC that cap hospital facility price growth at percentage changes in inflation. So CPI +1. We give you a point above the rate of inflation, which, by the way, in 2023, our rate cap for hospitals was 7.3%. So there are some downsides to tethering your regulations to inflation. On the point of primary care, what I've been hearing is that physicians don't necessarily see the money that is paid to the ACO. We are proposing regulatory changes that will attempt to push more money to the physician practices directly by requiring that the payers utilize what I'm calling service-based payment mechanisms. So through claims, like increase your reimbursement rates. I know that's not a popular topic writ large in healthcare, but in primary care, I think it's necessary. So utilize fee-for-service in places, right? And the other mechanism is through primary care subcapitation. That's enriched. That includes payments beyond just, whatever was spent on evaluation and management services and preventive care in the previous year trended forward. No, it needs to be additional payments for quality, for integrated behavioral health, for care management. There will still be monies that are paid to ACOs. They will still provide centralized services. But I've even heard from some Rhode Island payers that once they make the payment, they lose some of that visibility. So that's something that we need to try to correct. Did you want to add to that?
I was going to take a step back. If you listen to Cory's response, Jason was very clear. He did what a regulator does. He says, we are the source of information. We don't make policy. And congrats. That's what you should do, especially when there are legislators in the room. Cory is making policy. He's not making massive policy, but he's making adjustments based on what happens. And I do think that's something sorry to get into political science discussion, but what's the degrees of freedom that a regulatory entity has to make adjustments as they go along while preserving accountability to the legislature? Health Insurance Commissioner still has to answer to the legislature, still gets beat up around his budget, still has to answer when providers go to him. But he's got his office has some latitude to respond, which I think is really important. Because imagine trying to have this conversation with the legislature that's got all these other things that they have to worry about. It's incredibly complex. So it goes back to the first slides that he had about the powers and duties of the office in Rhode Island.
We also have ACOs. So every one of our ACOs is a little bit different. And I'm not going to convey any private discussions I've had with health plan executives or provider executives, but it's interesting. Those ACOs that have really emphasized care management have taken on additional functions like UR, some of our ACOs have taken on Medicare Advantage risk. That has worked well for some and has worked very poorly for others. So we're at a moment now where actually it was this week, Monday, I convened our Payment and Care Delivery Advisory Committee, which is all of the health plans, the ACOs, interested parties, retirees who have no skin in the game, who are former doctors and can speak freely without fear. And it was interesting. On the one side, there's a lot of concern amongst the accountable care organizations about the adequacy of their existing payments and the risk structure to their contracts. And I think the insurance companies are learning along the way. And I'm sensitive to and sympathetic to both sides. Some of the infrastructure payments made to the ACOs haven't changed on a PMPM basis in several years, but I guarantee you a care manager is more expensive to employ today than they were in 2016. So lots of unique issues we have to work through. But fortunately, like New Hampshire, we're a small state, so I can literally get everyone into a room together.
And you can use your powers and duties to facilitate, to nudge people towards accountable care. Not go all the way, but not have your hands off. So how do you how does the system, in this case the state of New Hampshire, learn what works and learn, even as they're competing? Because that's kind of what Rhode Island's been doing around accountable care.
Don't underestimate the value of having a public conversation on a thorny topic.
We have a question from an online attendee.
Yes, so just for the folks here and online and the panelists to be aware, we've got about 10 minutes left for this segment.
We get off.
This individual asks, excuse me, they said, you can't lose weight without a scale, but the number of pounds lost is only one measure. There may be other and more important measures that show the value of weight loss. Similarly, even without the cost target being hit, what are the other measures of success for these efforts?
I use that scale analogy, so I better respond to it. Yeah, it doesn't do any good to lose the weight if you can't make your laps, if you're not exercising, if you're not enjoying a healthy life. Commissioner Betancourt referred to this at the start. I think some of these national state health performance Commonwealth Fund puts out on them are pretty good measures because they get to that notion of, do we have everybody insured? What's life expectancy? Disparities based on race, ethnicity. So you need this composite scorecard. Affordability, weight loss is part of it. I would think it's harder to hit those things if you're particularly costly. And the other, I would note in this sort of, don't use your number 5 ranking as it's legit, it's real, you should be proud of it. Don't use it as a point of complacency. As a friend of mine says, another Rhode Island health person, he says, it's a little bit like having the best seat on the Titanic. And so we all got to work on this.
I'll briefly add, in our annual reporting, we publicize quality performance by payer and provider. And recently we've developed some public health and health equity improvement measures so that we can concurrently track the spending growth and changes in quality and public health.
Thanks for great talks. On the clinician and provider side, a lot of us try to just split our efforts between national level and state level work. And Deb has convinced me with her matrix to focus on what we can do in the state. So, Mr. Koller, I was really looking forward to the article that you and Elliot Fisher just published in the New England Journal. And I commend others to read it. I was looking at it for inspiration and hope that state-based solutions are going to work. I noted 2 things. Most of the progress that you were proposing seemed to me to be aspirational rather than documented and really evidence-based. The other is that it also requires 50 states to figure out what to do. As they did in Canada, took a short while for there to be enough momentum for all the provinces to get on board towards a general acceptance of of policy. But I'm wondering if you can, based on your work with the Peterson Millbank program, talk about how likely it is that we're going to achieve national results by working at this state by state, and how much of it we should be working with our U.S. congressional people and our friends at CMS to try to develop U.S.-based solutions.
Great questions. We could go for a lot longer than 10 minutes on them. I would point to the first lesson that I put up there, where we've got some comparable data. Cory's not going to talk about this because he doesn't want to brag and boast. It's not by accident that Rhode Island was below its target and was the only one of the 5 states that we're measuring that's below its target. The things that Cory is working on, that the office is working on, I think we can show has evidence that it's making sense and producing results. It's not always popular in any place because not everyone is going to have full rate review in the commercial sector, but it makes a difference, and we can learn from that. You're absolutely right, though. We gotta, at some point, these solutions have to be replicated we have to learn from the states and do it at the federal level. I think the signs of hope that I would say that are out there around the lessons around accountable care that physician-dominated ACOs tend to do better. We need to act on that evidence. More practically speaking, the Medicare fee schedule next year is actually going to contain a significant bump for primary care, what's called advanced primary care management codes that actually pay primary care physicians on a capitated basis to do chronic care management, resulting in a significant influx of money. We need to take that and run with it. It's a little crumb. It's not as much as other stuff. But man, I'm going to be leaning on Cory to make sure that all the health plans in Rhode Island are paying for those APCM codes, and that we're spreading those other places. Because that's what, as Medicare goes, so goes the nation. That's why primary care is undervalued. And so when we get those little bit of moves, we got to push them and run with them.
Two more give us one here and then deep.
Thank you.
Chris, I noticed on the slide with the medical debt that California has a really low medical debt, and I didn't know if you had any insight as to why it's so much lower than the other states.
I'm not familiar enough with the SIP data to be able to say what that is, so I would be afraid to hazard. There are smarter people than me who can answer that question.
Hi, Lucy Hodder. Thanks for being here and being back in New Hampshire. We get lost in data often. There's lots of data that shows lots of different things, and everyone has their data points they want to show around equity, public health, et cetera. So I think you've said it some, but can you just remind us why measuring with this fundamental and objective cost growth across all payers, like Rhode Island, like we talked about earlier from Jason, why is it so important as a starting point for the conversation of affordability?
Why don't you start with that? No, Charlie, I've been talking to her.
Sure. I will speak from my experience. So I've worked at OHIG since this man hired me as an intern in 2011.
It's the apex of my professional career. It's been
in some capacity. I took a brief stint in the nonprofit world, but I've been there for over 10 years. And I have never felt more empowered as a policymaker than I do now because we have this data. We've got data on healthcare spending, not just from the insurance companies, as I reflected here, but we've also used our APCD in ways that we never have. And I think a lot of states don't have the public-facing APCD reports. We can't have a data-driven conversation about health insurance premiums or affordability unless we have a baseline. And we now know where the money flows, how it's spent. I think there's an additional level of analysis that will be important in the future. And as we're measuring spending from insurance-based sources, I want to know how it gets allocated within provider organizations. I want to get under the hood of that because healthcare spending becomes provider revenue. I want to understand changes in provider operating costs between labor, supplies. I want to know how they're spending their capital investments. So there are future endeavors, but in in very specific instances where we've had to respond to legislation, I have a wealth of data now that I can use.
And what I would add to that is we were talking about kind of the regional, this is what makes New England fun. Yes, we're learning from Massachusetts the idea of having a cost growth targets are, I think it does two things. It gets Medicaid, Medicare, and commercial in the same place so that we get rid of the first response of cross-subsidy questions. And it gives a fact base that is not driven by someone at the table, that's being put out by the Health Policy Commissioner, the Office of the Health Insurance Commissioner, the Department of Insurance, where Rhode Island and New Hampshire can beat those smarty pants guys in Boston is actually to do something with it. Because for 10 or 15 years, they've been putting information out and then getting in a stalemate when the legislature hasn't been able to act on it. And so bless David Seltz and David Auerbach and Chia, they keep putting out better and better reports with more and more data and little cars going up on their trends and stuff like that. But we in Rhode Island or in New Hampshire can actually get people in a room and figure out what to do with it. And you, in bigger states, you can't do that. And so that's the opportunity here. And your solution's going to look different from Rhode Island. I think there's a lot to learn because they've actually got results that prove it. But their primary care physicians aren't particularly happy either. So maybe you can show Rhode Island how to do that stuff. But that's, Lucy, I think the cost growth targets gets everybody to the table. It gets across Medicare and Medicaid. It's an independent source. And then it kind of spurs us to do something about it.
All right, Ben from the Hospital Association. That'll be our last question on this topic specifically.
Thanks, Commissioner. Thanks, everybody. I found it interesting, the construct of OHIC and its requirement to bring in providers and understand their sustainability and what they're going through, too, as part of your oversight, not just on the insurance side. So I'm wondering if you can share some of the details of what you're seeing for provider sustainability and vitality in your state, whether there are trends in independent practice moving towards a larger system in order to maintain that financial viability and afford access to people in your state, and how that contributes to the overall effort to try to reduce healthcare costs through the work that you're doing. So a couple of points there, but the vitality of your providers in your state.
Sure. So I think it depends on the provider. I don't get complaints from the orthopedic groups. I think in terms of hospitals, we have some hospitals that are incredibly challenged now that have largely government-funded payer mixes, and I'm not sure what level of commercial reimbursement could ever put them on a better financial footing. I think there's opportunities to look at how much we invest through our Medicaid program. Like, all states understand the Medicaid game. You can bring in new money from outside of your economy when you change your rates. Where my concern is focused is primary care. We've had a primary care expenditure requirement, a multi-payer initiative to transform primary care since the time that Chris was there. And I think we can say, absent those initiatives, we'd be in a lot worse place, but it doesn't mean that we're in a great place today. I think at some point, the independent practice will become economically not viable if it isn't already, because we've seen a significant amount of associations or acquisitions from independent practice to hospital-driven system. And when you look at the hospital's financial statements, you see a loss on those books too. You see them losing money on their physician practices. For primary care, the issues are upcoming retirements, inadequate funding, administrative burden. We did a whole report on this in 2023. Not at anyone's direction. I read an article one day about doctors having a hard time finding doctors. And so I said, you know what, let's take a look at the state of primary care in Rhode Island and do a strategic reevaluation of our initiatives. We published that report in December 2023, which informed much of our recent rulemaking. But we found that, if we don't take action across commercial, Medicaid, and hopefully leverage some of the improvements at the Medicare level, we're going to be in a bad place in 3 to 5 years.
I would, this is be careful about doing policy by anecdote, but sometimes the anecdotes are really good.
Yeah.
We have a hospital in Woonsocket that is on the Massachusetts border that has a miserable payer mix, high uninsured. It's a impoverished mill town, and they were in receivership 15 years ago. And this fast-talking cardiac surgeon came down from Boston to say, I'll bail you out. And we came this close to having that hospital bought by Stewart. The combination of the price growth caps and a really robust conversion act sent Stewart away with its tail between its legs. They were angry. They went and sued a few folks. The hospital went to a for-profit. It wasn't that, this is a big nonprofit, it was established nonprofit run by the community. It was bought by for-profit, Prime Healthcare. Fast forward, that hospital has positive margins for the last 5 years. They have a hospital residency program. They're doing it on a Medicaid payment, on a big high Medicaid mix. And some of their colleagues, also independent hospitals with a much better payer mix, are torturing him about the inadequacy of their rates. Landmark and Woonsocket isn't doing it. And when you talk to them and ask them why they're doing it, how they're doing it, they say, we don't own physician practices and we just manage our revenues. We manage our accounts receivable and we bring it all in. I said, so it's checkers, not chess. He said, absolutely. And so sometimes in our delivery system discussions, we run to the big solutions as opposed to focus on the simple thing. Make sure your hospitals can deliver good inpatient care. Make sure that you have a strong primary care delivery system. Stay on top of your finances. And so, again, it's an anecdote, but it's a pretty powerful one.
Wonderful. Thank you very much. So in order to ensure that we are staying in compliance with state law, I've halfway complied by having this report produced. But the other half of that is to provide for a public hearing. So at this point, I want to just pause this discussion to see if anyone has comments generally about anything that we've discussed this morning or generally about rates or cost drivers. We get those questions out of the way. We'll use the remaining 5 to 10 minutes we've got left to dive back into the discussion with our panelists. Sure. Andrew?
Sweet. Sure, there's nothing else from our outline. Yes.
Thank you. I missed the first 30 minutes, so I'm making up my time here. Marie Ramos. So I think something that we haven't spoken about and is important, particularly in New Hampshire, is the role of our community health centers within the state in the delivery of primary care in the state. We are at a desperate level of need for better support services for this particular sector. And we're unique in a sense that we have many health centers in the state that do have insured patients that's higher than our neighbors outside of New England. So I would encourage us as we're having these conversations as to how can we better support our health centers in the state who provide so much care delivery within our rural areas. And also how do we help promote these additional types of diagnosis codes and CPT codes that can help inform the social drivers of health aspect that we are all interested in. At this point, health centers are not incentivized to necessarily diagnose and code effectively and efficiently, and that's a huge problem. So I want to make sure that that is on the record as well.
Appreciate that very much. Other comments? Just a quick response to that. We're proud of the relationships that we've built and continue to build with providers of all types across the state. We have conversations along the line that you've described. We've actually issued bulletins to try to assist providers to understand which codes they should bill for particular kinds of services. We appreciate the fact that that is a complicated and sometimes a bit of a black box for providers who understandably are focusing the predominance of their attention on helping their patients. So we'll continue to do that work, of course. The other aspect of this is having a continued conversation with the legislature around workforce. You have to have the people to physically work in these facilities, and There's not an industry in the state right now that is not really hurting for workers. And so that's obviously a far broader and far more complicated problem than anything we as an individual state agency can handle. But I think those are some of the key points, and I appreciate you bringing this up. Anything else? All right. I will officially close the public hearing. Any additional questions for our panelists? We can dive back into that if we didn't get to anybody who wanted to engage with them. Everybody's good? All right, well, let's have, just under the radar. Here we go. Oh, boy. That's a tough way to start a question, Deb.
That's okay. What is the time horizon, do you think, in reality, for achieving affordability in healthcare? Like, Chris has been at this for a little bit, and Cory's continuing, right? But realistically, like, the policy steps are amazing. But is healthcare affordable yet? And when does that get to happen?
What?
It's like
I think the challenge with the affordability discussion is that what is your preferred end state? Like, is it what the federal government determines as affordable health insurance for purposes of the exchange subsidies? Is it some other metric? From our perspective, we look at a number of different metrics. We look at average family premium relative to median family income, for instance. So I'm not sure at what point we can reach a metric that says this is the affordability nirvana and we're done, right?
And Deb, this is a bit of a dodge, but it goes to a question that Lucy asked. I think the affordability conversation is the catalyst. It's not the end in and of itself. By focusing on affordability, you can get to these questions of what do we want our health system to be like, and what I call, you can get the other 80% engaged, meaning the other 80% of the economy. You love quality measures to pieces, love primary care to pieces, but you're not going to get people really excited about that. You can get people to talk about affordability, and then that starts to have a conversation of, what do we want for our community? What do we want for our society around our life expectancy, around our disparities? So affordability is kind of focusing on affordability is a way to get everyone to the table so you can have the broader conversation.
I think we have given pretty poor answers to this question. But let me try again. Let me give you another.
Well, remember, it started out with the recognition that it was unfair. So
I like it better when you worked for me and you didn't have to be as polite.
Cory's going to let me try to answer. So
Sure.
From my naive perspective, it's a really good question. I'm surprised to have not heard anybody ask, what are we paying for when we pay our health insurance premium? What do we want insurance to pay for? So I'll point you to the CDC MMWR, which is the Morbidity and Mortality Weekly Report. It tells you everything that goes on with Americans with regards to their health. And then compare that to what we use our healthcare dollar to pay for. I envision and dream about a healthcare delivery system that pays for the things that really sicken and kill people, morbidity and mortality burdens. I know, having seen the last two legislative sessions, that we ask our healthcare delivery system to pay for a lot more than that. To me, that's patently unaffordable. So we can't hold independent the morbidity and mortality burdens that are printed on that report every week, independent from our healthcare delivery system now as it stands. That's my naive answer to that question. Let's keep that central in our discussions about healthcare affordability.
Yeah, I think Jason and Chris have touched on an important point, and that is, how do we ensure we're getting value for the dollar? But in Rhode Island, a data source that I'm really thrilled we have, every 2 years our state-based exchange does a household survey. And so this is an ability for every 2 years for us to take stock of what is going on among Rhode Island households in terms of affordability burden. So percentage of respondents' households that struggle to pay for medical bills. We ask them, have you had to use up some or all of your savings? Have you had to incur debt? And those metrics had been going down for a while. So you can read right to left. They've been going down for a while, but in the most recent version of the survey, they've ticked up. So the trend of those metrics, if a greater percentage of people are having to take on credit card debt or reporting problems paying medical bills, then that is an indication that there is an affordability challenge in the community. I'm not sure how it's distributed. I also personally question, why can't all those numbers be driven to zero, right? And then there's another element to this. When people report barriers in accessing care, it can be due to an affordability burden. Maybe it's because they have commercial insurance with a high deductible and they can't afford to pay that deductible. Or maybe it is that they have Medicaid and they can't find a provider that will take their insurance. That is an affordability burden. So I think as I had a chance to reflect upon your question while Chris was answering, those are some of the metrics that I would look at to get a sense of, are we making progress on affordability or not, as opposed to, are we in a position where we can say that health insurance is affordable? It's not affordable anymore. Look at the percentage of people on exchanges that are subsidized. Imagine if everyone who had a private employer had to pay their full premium. That's not affordable.
Yeah. Wonderful. Well, let's have a hand for our panelists, if you would.
Okay, I have some I just kept thinking about it. It's a good question.
Yeah. So a little bit of a gift here for our panelists. Cory, don't worry, it falls under the threshold of a gift.
Great. You can go little with my Nashby mug.
There was there's a certain criteria that we all use for designing our Yetis. So one last housekeeping item and then just some brief closing remarks. The first is that public comments can be emailed to the department until November 15th. You can do so via healthcareanalysts@ins.nh.gov. Just go onto our website. We'll make sure you see where you need to go. Again, so pleased with the presentations today. Really, thank you, Jen, and the team in Oliver Wyman. Thanks to our panelists here. It's been, I think, a very, very informative morning. Just close by saying that one of the things, and I haunt Dr. Aziz about this, and Morgan and Karen hear it quite a bit as well, they do a phenomenal job of collecting data. I'm constantly getting requests of the latest and greatest gadget or program or what have you that is going to bring in more information for us to take a look at and analyze. But I have always stressed that you can drown yourself in data at the end of the day. What you need to focus on, I think what has to be a priority, is ensuring that you are taking in data that you can do something with, that translates into action, that translates into an important conversation that ultimately benefits the consumer. And so I always try to keep my team focused on that when we're talking about data. The other thing I'll say is, as you might have seen on television, there's going to be this thing in about 10 days or so. And that obviously is going to usher in a new governor, regardless of the outcome. It's going to bring in a new legislature. And so the work for us, and I think we all have to take a little bit of responsibility in this, is to ensure that we are updating our legislators, especially the new legislators coming on board, about where we are, where we think we need to go, and the right way to get there. And certainly we're going to do that as a department. But for those of you who are out there in your individual roles, it's going to be really important, again, to do that outreach, to bring them up to speed, to get them the data and the information that they should consider as they launch into the new legislative session. And the last thing I'll say, the gentleman who raised this important point unfortunately has left, but he had talked about states working with each other. And I'd be remiss if I didn't talk about the work that we do with the National Association of Insurance Commissioners. It's an organization of which all 50 insurance commissioners throughout the country, plus the U.S. territories, we get together approximately 4 to 5 times a year, and we talk with each other. And a lot of times there's some comfort in that I'll say to the commissioner in Missouri, we're experiencing this in New Hampshire. Are you? Yes, we are. And then 2 other commissioners, having overheard that conversation, will join us and they'll say, yes, we're having that problem too. So there's some comfort that some of the challenges that we face are not exclusive to New Hampshire alone. And there's comfort as well in that we've got this group who can pool ideas, who can bring additional data to bear to help us understand what's going on and what we need to do. We also have a great communications chain with our congressional delegation. In fact, the NAIC flies me down once a year to talk with our congressional delegation about important issues that are impacting consumers and impacting the insurance industry. And those are always very, very productive and fruitful conversations. So those conversations are taking place. That collaboration is taking place and will continue to do so. I am a big fan, as you may know, of the state-based principle of insurance regulation. It's the last bastion of the American economy that is state-based in terms of its regulation and oversight. And I think it has served the public and consumers very, very well. Me personally, I don't want the federal government involved too much in this because we have the ability to act faster for the consumer. We have the ability to be here on the ground. I think the last 2 or 3 weeks have really brought home that point in the sense that you might have heard there's some disruption going on in the Medicare Advantage market. Well, we have nothing to do with the regulation of Medicare Advantage at the state level. But where did all of those seniors who were confused and who had high anxiety go? They came to us. So we took a pretty intense crash course into Medicare Advantage, and we got the seniors the best information that we possibly could. But that's the power that we here at the state level have to be able to best assist consumers. But we'll continue to work with anybody and everybody who wants to work with us to produce the best outcome for the consumer. So again, thank you all so much for joining us today. We hope it's been, again, an educational, enlightening experience for you, and we will see you next year. Thanks so much.